Okay, I'd like to welcome everybody to direct-to-consumer genetic testing, impending value and the path forward. So first we'd like to introduce Dr. Geeta Rao, who's the CEO and co-founder of Springboard Life Science. They're all under their names, so you can follow along with that one. Dr. Snyder, professor and chair of genetics at Stanford Center for Genomics and Personalized Medicine. Dr. Berg, chief science officer, translation biology for Eurofins Pharma Discovery Services. That's a mouthful on that one. Dr. Singh, Anita Singh, CEO and co-founder of GenID Solutions, and Dr. Greg Turnan, sorry about that. When I first read it, it was okay. Director of Precision Medicine and Research, Sutter Health, CPMC Research Institute, also professor at UCSF Department of
Epidemiology.
I know. You guys ever get where it's been a long couple days and you're just... So that is your panel for today. Geeta will take the role as the moderator and walk through everything with everybody. Thank you.
Got it. Thanks, Ginger, and thank you all for coming, especially given the very interesting panel next door. So really appreciate your presence here. We have an amazing panel here today, so I'm very much looking forward to the discussion. Let's just jump right in and go down the road and talk about what is it that you guys do. I mean, what is it that, and in particular, why don't you talk about the genetics and the genomics aspects of what it is that you do?
Okay. So, well, I am chair of genetics and I run a center for genomics and personalized medicine. I'm an academic here at Stanford, and we do multi-omics profiling. So genome sequencing is part of it, where we do sequence. I should point out this is mostly based on healthy people. We try and profile healthy people, see what is a profile look like for healthy, and then see what happens when they become ill. A lot of the folks are at risk for type 2 diabetes, and so we do genome sequencing to predict their genetic risk for not just diabetes, but other things as well. And then we also do, in addition to that, many other omics as well. In fact, we follow people with 14 different omics profiles. We do wearables. I have 3 smartwatches on me right now. And so we try and bring big data into managing health, so go beyond just standard testing into advanced and what we call emerging technologies. We're trying to understand what it is to be healthy, and then again, find out what happens when people transition to disease.
Okay. Wow.
I am Ellen Berg. I'm a CSO of translational biology at Eurofins, and I'm an entrepreneur and interested in technology innovation in drug discovery in the preclinical space. And our technology is human-based phenotypic assays, so to try to predict human outcomes from large in vitro data sets of combining genetics, genomics, and proteomics data to predict adverse effects of drugs, et cetera. So we're interested in how to layer on this, the personalization of your genetic data onto how drugs are going to behave in you. So that's what we do.
Hi, I'm Anita Singh. I'm an ex-NASA engineer that's spent the past 10 years working in healthcare IT. I'm CEO and co-founder of GenID Solutions, and we're the step before you do genetic testing. We have a software tool that analyzes the patient's electronic medical record, and we can identify whether or not the person should be further screened for hereditary cancers.
Hi, Greg Turnan. As a researcher, I do what we call genetic epidemiology, so I do sequencing and other types of genomics in large populations of people, mostly around aging, so trying to understand healthy aging and different trajectories of aging and layering genomics and genetics on top of that. At Sutter Health, I direct a large initiative in precision medicine where we're biobanking hundreds of thousands of people longitudinally, so we have multiple samples over time on people. We integrate that with our decades worth of electronic health records, And we're basically trying to use that as a platform to discover markers of disease progression and treatment response, but also to translate from a research environment, like the discovery research I publish and my colleagues publish, and see if that actually has value in the clinic or value for treating patients and understanding disease progression. Because a lot of times we publish and go on to the next thing and don't ever really take it the next step in understanding how that can help patients. And so that's what we're trying to establish at Sutter for 3.5 million patients.
Okay. So before we get back to the next discussion point, I wanted to get a sense for the audience here, because there were a couple of things I was going to ask about. So how many of you are entrepreneurs or from the innovation space? A couple of you. And how many of you are scientists? Sort of, a couple will admit to, okay, a couple of hands up there. And how many of you are in the research or, what other areas, spaces are you in? Okay, anyone in business, in academia as such? Okay, so it's a bit of a mixed bag. So a question, let's very briefly touch upon the economics of what you do and why do you, well, how does it get paid for? Like what's the value of it? So let's start with you.
Yeah, well, what we're doing is a research project, I forgot to say, but we've spun off a number of companies over the years, and we are spinning off some in this general space. I mean, that is the fundamental issue, who pays for this stuff, especially because it has not yet been validated in the clinic, and it hasn't been shown to be, reimbursement doesn't happen until you show it has usefulness and outcomes and that sort of thing, and that is lacking. So it always has to start with, trials and things of that sort. So to be honest, what usually happens is rich people get access to it first because they pay and they get it going, they show it has value, and then it spreads more broadly. And that's the model. It's not one I necessarily agree with unless the government can step in, but that is a common scenario.
That's a really interesting point. And when I had an earlier discussion with a couple of the panelists around, from a market acceptance point of view, what's the economic pathway to get there? So Ellen, you want to talk really briefly about what is it that?
Yeah, I think that's the challenge. It's the chicken and the egg, right? You need the money to show the value, and you need the value to get the money.
That's right.
So,
in your case, you have a big pharma.
Yes, yeah. In my case, we're funded. It's a B2B. We're funded by pharma companies doing research.
Everything you're doing is filtered then through the lens of, is there going to be a saleable drug coming out of it, or a saleable
Yes. And there are also assays that come out of what we do.
I guess.
And then those would be then commercialized. But the challenges in the preclinical setting or in drug discovery, they just don't have enough data. They usually don't have enough patient data. Individuals, so that's a challenge.
So at that point, it's still like you're hedging your bets. Maybe just an assay that's a consolation prize, or it could be a therapeutic. Okay, all right, Anita. I mean, this is your second startup, and so you have some sense for what it takes to get from here to market, like from zero to market. So tell us a little bit about the economics here.
So we're an early stage startup right now, but we are currently selling to doctors. They do see the value because we save them the 5 to 10 minutes it takes to do a cancer risk analysis on every single patient. And in the clinics where we're live, we actually have been identifying 20% of the patients for further screening. So it's a significant amount of time that we're saving them. And for the patients that we do identify, they do spend more time with them, so they get to charge more per patient. So there is a return on investment from that.
So it's kind of really a screening that's not part of the traditional reimbursement model, but it's one that you're sort of bundling in, or you're showing the value add enough. Okay, all right, that's interesting. Greg, let's talk a little bit about who pays for what you do and why.
Right. So our business is a little different when it comes to our healthcare system and how we're going to try and bring this technology to improve outcomes in our patients. So we, through philanthropy and the system, have basically funded our biobanking initiative. We're almost done with our precision medicine initiative. And for me, a lot of people don't like the term precision medicine. For me, it's a really straightforward definition. It's the research is the key here, that helps us understand and identify biological markers, genomics, to help us better understand patient disease progression and treatment response. So think of a marker that can help us distinguish between a rapid progressor of multiple sclerosis and somebody who's going to relapse and remit over time. So those are the types of needs in the field. And so our model is that we don't have a genomics institute, we don't have a huge bioinformatics presence. We've invested in the biobanking. We have, again, decades worth of electronic health records to help us identify cohorts for research, and that's a huge amount of leverage, and we're gonna partner. We will partner with industry, with pharma, whoever it is who has the best tools for whatever disease we're trying to help our patients have better outcomes for. And so our model is that when we form a partnership, we cover our costs, revenues that come in go back into our research program, and discoveries made through that research can become part of our service line strategy to help improve patient outcomes. So that's how we're foreseeing this. We've invested up front, and we're going to partner to make the discoveries and benefit.
So you're sort of monetizing an existing data bank, if you will, that you have.
That's right, but the key here is that we're not selling data.
No.
We are partners in this.
Just selling access.
That's key to us.
Okay. All right, so Michael has a book, Genomics and Personalized Medicine, what everyone needs to know. So copies available if anybody would like to buy one. I couldn't help but note, Greg, your title is Director of Precision Medicine, and the two terms, personalized medicine and precision medicine, have been used imprecisely. So let me ask you, Michael, do you see a distinction, and what is the distinction?
Well, I prefer personalized or individualized medicine because I don't think we're very precise yet. The goal is to be precise. I think it's a little bit of a misnomer to say we're practicing precision medicine. I feel like we're still too far away.
Okay.
But I think ultimately the goal is to make them converge. I also think there's a big part, at least the way we think about the problem. I mean, I'll back up slightly. I think the way we do healthcare now is completely wrong. We do it entirely built on, as you know, on people getting sick. And I think what you're hearing up here is people actually want to do prevention. And that's where we need to shift. It's not the business models for that are poor, so people are coming up with creative ways to do this. So, and I think a big part of the way medicine in the future is going to be, it will be home tests or some of this direct-to-consumer stuff, which I guess is a topic. I do think longitudinal profiling is going to be a big part of this. I think those longitudinal profiles, even the baselines, are very personal. That is to say, everybody's different. And how you proceed on these longitudinal profiles, you can set up individualized models for that. And that's why I like the term personalized or individuals, because you build individual models around people to follow their health and deviations from the health in any disease space you want to be in. So that's how I view it. That's why I like the term personal. And ultimately, if Greg and I converge, it'll be both personal and precise.
Precision. Okay, so
But we definitely don't disagree. We just use precision because that helps us raise funds. But the idea is it's the research that leads to the personalized medicine. So the goal is the personalized medicine. And
so Greg, you're making the medicine more precise, so Mike's team can make it more personalized.
Right, and so we can do that. I mean, if I could change the term, it probably should be, instead of precision, it should be accuracy medicine.
It's interesting. My goal is to make it more precise, and yours is to make it more personalized. That's
right.
Kind of cool.
Right.
Yeah,
Okay.
sorry,
So that's where and in some sense, what both Ellen and Anita are doing are kind of right in the middle of the two.
Yeah, and I just to add on to what Michael and Greg said, that I like personal because it's not only your genetics and maybe the single drug that you're taking, but it's also your environment, your stress, all of the other factors that are going to impact your well-being or your illness, so to speak. So
that's where it is. Okay. You have something to add to that, Anita? Or?
I mean, I can add a story about, we identified a patient once who was a clear candidate for genetic testing, but he personally had no children, he had no siblings, and so he decided not to get tested. And that's where you have that personal part of it as well. It's precision and personal, I agree.
Okay, so, you know, one thing that strikes me is that none of the four of you actually does direct-to-consumer. And,
That's right.
and then the other thing is that none of the four of you deals with just genetics. So one thing that's very clear is this sort of, this kind of futuristic vision of, you know, a baby's born and you take a drop of the baby's blood and then suddenly you predict the entire medical future of this individual is sort of quite far out there, even if that's even a possibility, right? So the reality is that there's genetics, and then there are a lot of other things that surround genetics, and each of you are looking at a somewhat different set of other things that surround genetics and getting into, and then creating something of value out of that. So and then obviously the very first frontier is usually diagnostic. You know, you kind of want to get a fix on what's happening before you start doing something about it, before you intervene. And historically, and I'll speak from my background, being in the startup space, that diagnostics has always been sort of the stepchild for investment. You know, you can always see the business case for a therapeutic. If you can prove that a therapeutic can improve outcomes or reduce cost or do some, there's a very direct benefit. The cost-benefit analysis is very straightforward. With diagnostics, it's more complicated because, you know, you have to look at it on a population basis. You know? So yes, there's value to everybody getting a diagnostic test, but there's also cost and pain and suffering associated with it. And so the trade-off is not always good for any given, and you can't guarantee it for any given individual. So you have to look at it from a population standpoint. And so that adds a second order of analysis that both makes the economics difficult, but also makes the value creation or the demonstration of value difficult. So with that in mind, you know, towards this trajectory of this futuristic vision, you know, where do you see both the gap? How far do you think we are? How far away do we are from it? Obviously doesn't have to be the drop of blood of the newborn, but, you know, how far are we along the way of making this routine or part of some kind of, you know, some regimen? You tell us what you think it is. And what do you think is the direction? What do you think needs to happen for us to move in that direction?
Want me to go first?
Yeah.
Okay, well, it depends what it is. If it is genome sequencing, I mean, I think there are creative ways of getting that involved now. You heard about Greg's for getting it into Sutter. But I think it is more than that. That is to say, I think there's all kinds of data collection things out there, and they will get adopted at different rates.
Okay, so
That is to say, I think the wearable stuff is taking off like a shot. And yes, those are fairly inexpensive devices, but the business model has to be, they have to scale. So there are, you know, Fitbit's $1 billion company because they're selling, it's not an expensive thing, but they're selling a lot of them, and they will be a health company soon. So I think that kind of stuff is it's already emerging in. We think we can detect whether you're getting sick before you know it just from your smartwatch because your heart rate goes up. I think that's going to be a standard app in everybody's smartwatch. So I think having your smartphone as your dashboard for health will happen in the next 5 years. That's a prediction, probably wrong, but it's not unreasonable. So that kind of stuff. And when genome sequencing becomes routine at birth, that one's harder to predict. It depends on the payment model and the things there.
There are
But
countries that are doing this now.
they're mostly being done at a research or philanthropy level. That's right. Yeah, the single payer systems have it all over.
Yeah, right.
Our system.
The UK.
So I can go on and on, but we should hear what some of the other panels want to do.
Right. So I guess
Yeah.
if I can paraphrase what you said, like that you're looking at the explosion of wearables creating this explosion of data of a particular sort. It's data around a person's actual lifestyle in some sense. That's the variable, which then at some point in the future you believe is going to get layered on top of the fixed data we have, which is their genetic information, assuming it gets cheap enough and routine enough. and then that's where you see the two coming together into this.
I even said before that, I think some of these will have intrinsic value of themselves. For example, and this I think will hammer, I hope, the spirit that we all have. I don't know if you realize, but you hear everybody's temperature is 98.6. Well, that's not right.
Yeah.
It actually ranges from about 95 to typically 99.5. Some people are higher on H or lower H. I myself, I'm 97.5. So that means if I go to a doctor at 98.6, he tells me I'm healthy and I'm sick. My temperature's elevated. And I guarantee that's true of a bunch of you in this room too. And the problem is you don't know that, and they never look back at the previous visit. They just assume that you're 98.6. So the reality is these devices are going to know what our baseline is. They know your baseline. So when it goes up to 98.6, you know something's happening. And I think that's the future. That stuff's here going to roll out very, very quickly, I think. And that will be direct to consumer, because just like you can go buy a thermometer to stick in your mouth, you'll be able to buy a smartphone that tells you your temperature's up.
That makes sense. Okay,
So,
so
how's that?
Ellen, let's talk a little bit about your view on where we are, how close to this future that that's the popular imagination.
Yeah, and you're a long way away, but the thing about data is that if you can aggregate it, the value goes way up. And so I think whoever's going to aggregate the data will pay to have it. Okay. So I think we're going to, very soon, everybody's going to have their genome sequenced because somebody wants it, and you're going to agree that it's
And it'll
worth
be
it.
cheap, right?
Yes,
Yeah,
it's not going to, or it may not cost you
$200.
anything because your health care provider is going to cover it because they're part of this. They see value in the aggregated data.
Okay, so you're saying if there are enough reasons to sequence a genome, enough people will have their genome sequenced that eventually it'll be universal.
Yes, and I think we're close to that because of these big programs that have got 100,000 people. Those are numbers where you can start to see interesting value come out.
Okay.
The larger numbers of patients, and then that will drive, I think.
Okay, so that's the direction that's the trajectory that you're looking at, but you still think we're pretty far from being, Mike's a lot more optimistic about how close we are, so.
Well, I think we're close on wearables. Again, it'll roll out different parts.
Okay.
The genome sequencing, bits of it are now, right? Geisinger they're sequencing 250,000 people. Some of that information will go back to their patients, and that's because they have a creative model for how to do that.
Yeah, and I think maybe the problem is the underserved markets. I think getting them on board
It's going to be harder. Okay. All right, so Anita, tell us your vision for how do we approach that futuristic utopia.
Well,
Metaphor.
how do we approach it? My immediate thought is education. I go into doctors' offices and I pitch my product, and I have many doctors tell me they don't know what to do if we identify a patient. So you can start there by educating the doctors on genetics and genomic sequencing, and you talk about underserved populations, you're talking about a lot of people that don't know anything about it. So I would say your first step is education, and I think Fitbits and wearables are a great example. My mom wears a Fitbit, and every single day, every time I talk to her, I walked, so many steps per day, and it's something I would never have thought she would ever be doing, but it's accessible. Like, we all know what a step is. We all know what, I walked 2 miles is, but sequencing a genome, how many people can really explain that? And I'm seeing it in doctors' offices. Doctors look at me and tell me, I don't know what to do if you identify a patient for me. So I think education would be the big first step on that one.
So really big gap there.
Really big gap.
Okay, in terms of practice too, yeah. Greg, so in particular, you're in the heart of the kind of the research physician community, much like Mike, where, what's your...
Right, so you're doing things that we know about, right? So you're looking at markers that are strongly linked to the familial cancer risk. Okay, so we know what those are.
Yes.
But people are showing up at their physician with their 23andMe test, and they're like, "What does this mean?" And I do research that ends up being part of those reports. And like, I don't know what that means. And so how is, so I think there's already direct-to-consumer genetics. It's been out there for a long time. You can get your genome sequenced now. But the thing is, we have to provide information, not just, sequencing. And if we, on the research side, still are trying to make sense of it, like, you unleash this for everybody else, it's really, can be dangerous. And, at worst, maybe it's just confusing, and that's fine. But what concerns me is not just the downstream interpretation and using that information to make decisions. It's actually upstream of that. Like, how good is the data? Like, what is the quality of the data you're getting? Because you go to any genomics institute, you talk to Mike down there, I'm sure he's got his own pipeline for going from DNA extraction all the way through the informatics to calling a variant and making a decision about that. And there are a lot of dodgy companies out there. Everybody's got their own way of doing this. And so nobody's controlling the quality of what you're getting back. So you really have to, like, from beginning to end, you really have to understand the process to know what you're getting into. And, no companies that's trying to make money off of you is gonna educate you on that. They just want to sell you a report of some sort. So
Right.
you just have to be really, really careful out there. And I think education is really critical here. But again, this stuff's complicated.
So Greg, tell us about what's your experience with doctors? Like, that's the patients we've talked about, but what about doctors?
Right. Well, I mean, the sort of not easy, but the easiest physicians to convince are oncologists. So as we sequence tumors and we find tumor driver mutations that can help us decide on the next therapy after they've failed on frontline therapy, resistant physicians are now coming around because they're seeing that this is helpful. And we have a program where we're pairing high throughput drug screening with that in vitro and in vivo models to help get the next treatment for the patient when they fail on the first one. And a lot of doctors who were resistant and now go to molecular tumor boards are really buying into it. And so, how can we scale that across our system? That's my challenge. But I think that was, that's I don't want to say easy, but we know where the tumor is and we can sequence it. So that's very helpful. But for a lot of the other diseases where we're trying to do risk profiling, that's very complicated, and so it's going to take a while for us to understand it before we even feel like there's a clinical application.
And I think it goes back to what Ellen is working on, which is so what if you can tell the difference between a profile of tumor A and tumor B, patient tumor in patient A and tumor in patient B. What if you don't have alternatives to treat them differently? The value of that information isn't that great. So that's.
But in some cases it is, right? Lung
Right.
cancer, you'll have 5 different pathways, and depending which of those is mutated determines which treatment you'll get. So there I would argue it's almost malpractice if you don't use genetic information. I would argue because you're 10 years, you're 5 years behind, and you're actually not serving your patients properly.
Yeah, I totally agree. Lung cancer is one where everybody should be getting their tumor
Right.
sequenced.
Not everybody is.
Right.
No, but they should be. You're right.
So this recent FDA approval for 23andMe to inform their customers, I guess they are, of if they have the cancer gene, whatever that cancer gene is. I don't know if it's proper one. I don't know which one it is. But you're saying what I hear from you, Greg, is none of that is worth a great. I mean, in fact, I'd like all of you to comment on it a little bit on what's the importance of that, because that's a sort of it's capturing the popular imagination that now I can send in a saliva sample on a Q-tip and they'll tell me my risk if I have the cancer gene. That's the layperson's interpretation.
I mean, just really quickly, you go from really rare variants that cause the disease, like cystic fibrosis,
Right.
all through the spectrum of you can be a carrier but maybe not get the disease,
Right.
up to where you've got a mutation that explains like under 1% of the risk of a disease. So that's the spectrum.
Right.
And so it really depends where on that spectrum what you're sequencing for And so it'd be interesting to hear your experience because you're in that middle space where people can be carriers and at high risk, but they don't necessarily go on to get the disease.
Yes, that's definitely a big part of this. You can get a positive test result from a genetic test, and your doctor can say your family history is not one where I think you need a double mastectomy or an oophorectomy, some kind of medical intervention. I will comment on the 23andMe. They're only looking for 3 of the BRCA genes, and they're all related to Ashkenazi Jewish descent. And they're very clear on their website that they're only looking for 3 of them. So you can test negative on this test and still be a carrier for the other, was it 20,000 BRCA genes or whatever there are. So you are not in any way cleared of the test by getting a negative test result there. So
I'm just surprised. I think the FDA has been under a lot of pressure to help move forward some of these advancements, and in some sense they kind of caved to political pressure to let this one through without the usual caution around, I'm sure the labeling is pretty extensive around how limited the value of that is. But
It is a very, very specific set of mutations, so it's not at all a general
okay.
breast cancer or even familial breast
And
cancer.
I don't think it's actually costing the customer, and in their case, it's their customers, not patients, right? So it's not costing them anything over there.
I think what's interesting though is the principle of Unleash.
Right, exactly.
Right, which
That
is what
was
I think
exactly.
you're
I think it's the
getting
thin
at,
edge of the wedge for them, and then it allows them to kind of be out there and expand on it, or at least sell investment money, sell the investors a bit more. Okay, so I'm going to throw it open to audience questions. We have about 15 minutes, so go ahead. Yes.
Can we get you a microphone, or what do we do here?
It's okay, I can just talk. Can you
Okay.
hear me okay?
Yeah.
So you guys have brought up a great spectrum of different phenomena. I wanted to commend Ms. Rao's comment on the degrees of freedom that you're introducing with these diagnostics are really very interesting. So I have a question to the panel. You're doing something like when you took a glucose reading and you was like whack-a-mole, get it back in the range. And then you turn it into curves, and suddenly the clinical rationale for managing this is blown out of the water. Am I circling a wave? How am I interacting with this control system? You're turning that into multi-dimensional, totally missampled kind of information. Because like take even BRCA, you have a tiny subset group who has high sampling, and they've manifested the disease, and you get the markers. But does that extrapolate to somebody who hasn't manifested the disease? And I think you guys are, I'm sure, at the forefront of this thinking here, but how do you manage the fact that you're totally changing the equation for clinical medicine?
Yeah, great question. That's a really good question. So actually, let me start with Anita asking a response to that, which is, pretty much sometimes the standard of care is predicated on knowledge that didn't exist at the time the standard of care was established. And now you have new knowledge, like some of the screening that you're doing. I mean, all 4 of you are in that space, but how is that, how do you manage that? Maybe you talked about educating physicians for one thing.
yeah, I mean, I would definitely, I was leaning towards education. Once again, you need to educate the patients on what a test result means. You can get a positive test result from, let's say, 23andMe, but you have no family history, then you're going to go take it to your doctor, and your doctor is going to say, okay, well, you have no family history. They're probably going to send you, my guess would be, to another genetic testing company to get a better test done. So you've spent your $199 on 23andMe, and now you're going to spend your $3,000 on something else. So, I mean, I think education is where you should start, and I think if you know your family history, or you have some reason why you want to take a genetic test, you should go talk to your doctor about it and see what they have to say.
It's even within the realm of the doctors, though, if you don't have the natural history, like take, for instance, factor V latent, it's a very common example. You're going to have a genetic risk factor for something that theoretically predisposes you to a problem, but it has no clinical significance or natural history if you haven't had that event.
Right.
It's hard to know though, because half of the BRCA mutations are de novo. meaning they appear, you know, in the child and they weren't necessarily there in the parents. And some of those are clearly crippling mutations. And you would argue that actually catching that is a good thing because they will go through monitoring. Some people may decide to have mastectomies or ovectomies based on that. So by not getting that information could actually be harmful. Actually, that is to say, if you had a de novo mutation and you didn't know it, you could get cancer just blindsided. So some people are arguing, I'm just putting out one argument, that all women should be sequenced. We could argue all people should be sequenced for BRCA mutations, because even though it's rare, it is actionable. If you and not that all mutations are decipherable. You raise that point; it's a really good point. Those variants of unknown significance you're not sure about, but a lot of them are. That is to say, they're strongly associated as disease-causing mutations. And so I think it's useful for people to have that information, if for no other reason, to get screened more frequently. So I add one more comment on top of that. We sequenced 70 healthy people and looked at their genomes in incredible detail, besides my own, which we've done. And 12 of them have clinically actionable information. One individual has a BRCA mutation. No necessarily case of it's a male, but no breast cancer necessarily in their history, but will get increased scanning. We did also find someone who had a mutation in the cardiomyopathy gene, and wouldn't you know it? Turns out he's a young guy, has a heart defect, which we picked up on a stress echo. Never would have seen it otherwise. Only got picked up because of his genome, and then we later learned his father died in the 60s and his uncle of heart issues. So, in fact, that's valuable, actionable information. He's on drugs now because of that. And so I would argue that's also cost benefit to the system, because if he gets a stroke and becomes incapacitated for a dozen years, it's very expensive economically. So one can make all kinds of, aside from quality of life, that's a big deal.
Yeah, but so these are anecdotal kind of situations.
But 12 out of 70 is still a decent number, right?
I'm not just saying you don't want to know. I'm just saying the clinical, what do you do? What is this?
Right.
Totally changes. And I'd rather know, but the actual what should you do then is different than.
It's usually increased screening, right? From this, half of these things are cancer related.
Well, then
They're
the reimbursement models,
They're increased screening,
and
that's not a bad thing.
Yeah, no, but then the reimbursement models or the care models have to change. The economics of care has to change around that, right? So this is where it's sort of a multi-pronged system, and every part of the system, whether it's the consumer or the patient behavior, whether it's the physician, practices, and whether it's the payer practices, have to kind of sync up with each other, with each advance in one or the other space over there. So that's kind of what we're seeing. Yeah.
And I want to point out that you and your team know how to handle the data and how to interpret what you should and shouldn't do, but out in the wild, I think that's where we have the.
Oh yeah, it's a mess. If you've ever done Veritas' genomes, if you get anybody from there, here or there? Okay, I didn't say that. Yeah.
So let me kind of, sorry, are there other questions? Because, yeah, go ahead.
Well, just to follow up on that, not from this space specifically, but like Greg was mentioning that something that might show an increased risk of, some marker might show an increased risk of disease or cancer at a 5% rate, 10% rate, or maybe a marker up from 1% to 2%. So, the answer is not to say that when you're clear, you reduce screening. It's when you are risk, in some risk pool, you increase screening. And insurance companies and outside of medicine, and probably medicine as well, are good at doing the risk model of okay, the lifetime cost of this person without, if I catch this later, is this. If I catch it now, it's this. And so I might pay up front more money to catch something that doesn't exist, or try to catch something that doesn't exist, but in case I catch it, I'm going to save a lot of money long term. So it's both a comment and a question. Is that seem like it's more exacting in terms of using a model like that?
So I have
of course, the hard part is, like you mentioned earlier, it's how do you put that in a payment scenario where
it makes sense,
it
right?
makes sense because now your insurance company might need to know your genetic risk profile to make that lifetime cost
Right.
function. So do you want to share that?
So, I mean, what you described theoretically, it works for a single payer environment. In the US, it simply doesn't work at all. And that's kind of the irony, that the advancements are happening here, but the benefits are not likely in the near future to be accrued to the US population. And I'm sorry to jump in here for the panel, but specifically the average tenure of a patient or of a customer in a healthcare plan historically has been 18 months. It's bimodal, it's 1 year or 2 years. Okay, so
Quick follow up on that. So
yeah.
does it lead into that then the best applications for, the best near-term applications for an economic model for genetic testing is actually in single payer healthcare?
Oh, for sure.
Right? Like, so why don't we just focus there instead of trying to waste the time saying?
Well, that's a different question, right? So that's a whole
This is
different question.
a
Yeah.
question, but-
So maybe this is a case of science leading policy. I don't know. Not in the current environment for sure. but I think it's not hopeless. I mean, at that point, I think, and
Well,
again,
two things that impact it,
yeah.
right? There are creative models like the
Right.
Geisinger one,
Yeah.
where they actually are sequencing, even while the cost is so expensive, by partnering with pharma
Right.
as a way to get the expenses down.
Yeah.
And the other comment is, of course, the hope is it'll be $100 to do this stuff, and then it becomes cost effective.
Right, and the pharma is interested if they can sell them, an expensive med. I mean, if the response to, if as Anita was describing, let's say you find someone, what does that mean, and what do they have to do about it, happens to be something that doesn't make any money for anyone, it's behavioral change, or it's whatever, or any substantial money for anyone, then no one's vested in driving that forward. So in some sense, I guess, Mike, you talked earlier about the explosion of data driving innovation. I guess new business alliances, if I may use that term, for each improvement in precision or each addition of precision is also, I guess, the other driver there. But in terms of the cost,
And I hope it would have value that Sutter could get more people on board because they offer genome sequencing, or at least some portion of that. If that adds value to their service, like, we will keep you healthier, and in the long run, that
Right,
should
we
add
can attract
value.
patients, and we can attract patients. and
Exactly.
Keep them,
Yeah.
keep them that way.
Yeah.
and then yes, and then if,
So that's another model
and
by
if we
which to
yeah,
make it work.
drive. I mean, there are other sort of, I would say, ways we make up for lack of single payer, and that people have found ways, the entrepreneurs in particular have found ways to tackle the system. But yes, that is a very big challenge over here. If there are other questions?
We're trying to get the simplest things in the world put into clinic flow. So
Right.
a patient shouldn't be released from the hospital unless they can walk 20 feet at a certain pace. Otherwise, they're at a really high risk of coming right back.
Right. But
I'm working with our gerontologist right over here at PAMP to understand probably the simplest thing they could do to know if one of their patients is going to become disabled is to watch them. And if they can stand up without their arms, they're okay. The moment they need their arms, they're really close to being disabled.
Right.
You don't need genomics, you don't need any of that.
So there's no money in that, Greg.
But getting that into a clinical workflow, like something that's a much stronger predictor than any of these genomics.
There you go. Yeah.
That's what's hard.
So let me wrap up, unless someone has another question. Actually, I don't want to cut short. No? Okay, so last couple of minutes that we have left, kind of bring it back to the consumer, or direct-to-consumer notion of what role do, I don't want to use the word patients, but what role do people have in owning or driving or being part of this genetic information enabled health?
Well, if we're going down the line, I think everybody owns their own data and gets access to it. Now, having said that, I think how that's given to them and how they deal with it has to be done responsibly. But I do think you are in charge of your own data. In the future, you're already seeing models where people want to sell data, aggregate it in certain ways. And so that's an interesting business model too.
Yes.
But I think that's how it should roll out, and I think people should get it, but get it in a responsible fashion.
Even if they don't own the interpretation of the data, they actually own the data itself, and they get to choose who gets it and who gets to interpret it.
Well, I would have let them get access to interpretation, but obviously you have to inform them and, you know, how to get a proper interpretation is not trivial, I think as others have said. So.
Yeah, I don't, empowering patients and people, empowering people to own their own data. And I think all of the analyses on those data need to be open and transparent. Because otherwise your data will be used against you.
Yeah. Yes,
Right?
yes.
Yes.
Yeah, I mean, and that's the biggest fear people have
Yes,
about
yeah.
losing
Open and
privacy of their
transparent,
data.
then they feel more comfort, sharing.
Okay, good point.
Yeah.
I'll make a comment about the direct-to-consumer genetic testing. I'm not opposed to direct-to-consumer genetic testing. I actually, though I definitely think a doctor should be involved if you have any type of actionable result from your genetic testing. In my case, my family history, my parents actually don't know much of their medical family history. We come from a rural part of India. And so something like 23andMe may possibly help someone like me because maybe I'll find out there's Parkinson's in my family or some other disease. But I do think that there needs to be some language between, you know, a company like 23andMe and doctors. So when a patient walks into a doctor's office with 23andMe results, the doctor knows what to do with it. Versus, as Greg was saying, doctors don't know what to do with that.
So you would say the responsibility then lies with the 23andMe's to speak both to the consumer and to the healthcare system, if I may put it that way.
Yes, especially if you're giving, you know, you're saying, hey, you're a carrier for BRCA, and a patient suddenly feels like getting a mastectomy, you know, I mean.
Yeah, right, because entirely
that's-
the Angelina Jolie effect, yes.
Yeah, that's a,
Very real.
you know, actionable results from that test, so.
Greg?
So I agree. Everybody should have access to their data and own it. You know, it's your right. It's your information. So a couple of observations: there aren't enough genetic counselors in this country to go around, and the ones that we have are usually focused on, you know, specific inherited mutations, and so that's an opportunity right there to, you know, bring interpretation to customers. And then a second observation is more practical in that, you know, it used to be the $1,000 genome was the $10,000 analysis, and that was the pain point. But now costs are coming down for sequencing. Even the, you know, analysis and interpretation is becoming sort of more streamlined and pipelined. The next big thing is going to be storage of all of the data, because when you get a whole genome sequenced, what does a customer own? Do they own all of the reads from their sequence? Do they own a downstream file? Because if you throw that in the sequencing away and you want to go back and sort of recall variants and things like that, that's got to sit somewhere. And these are huge files, and so that's just the, you know, the next pain point I think that we're going to hit.
Okay. All right, so I guess we're out of time now, so I want to thank everybody in the panel. That was great, and everybody in the audience as well. So people will stick around. Mike?